Hello, good evening, everybody. I am Dr. Saurabh Gupta. I am a consultant nephrology and pediatric nephrology in Max Healthcare, located at Max Hospital, Vaishali and Parparganj. So today I'll be discussing with you nephrotic syndrome in children and the new guidelines which have been updated by Indian Society of Pediatric Nephrology in 2021. So I will be discussing the steroid sensitive nephrotic syndrome guidelines. So these guidelines are based on the grade model which was proposed by the American Academy of Pediatrics. And there are ungraded statements which are basically practice points indicated by the capital X, which is not backed by sufficient evidence. If we go back in time, initially nephrotic syndrome was defined as a pentad, that is presence of edema, hypoalbuminemia with albumin below 2.5 gram per deciliter, hyperlipidemia with a cholesterol more than 200 mg per deciliter, lipiduria, and a nephrotic range proteinuria. Gradually, the lipiduria was removed from the definition, and the definition included 4 points. That is nephrotic range proteinuria, edema, hypoalbuminemia, and hyperlipidemia. The current guidelines, though, mentions that one should measure serum cholesterol and mentions that most of the patients have serum cholesterol more than 200 mg per deciliter. But there are few patients who might not have hypercholesterolemia and still they have nephrotic syndrome. So it has been removed from the definition of nephrotic syndrome. So here I would like to highlight the nephrotic range proteinuria. So if we do a dipstick, the dipstick which is available to us, either a multi-stick or either 2 sticks having sugar and protein dipstick. So if there is 3 plus 2, 4 plus protein, which corroborates to 300 mg per deciliter to 1 gram per deciliter of protein in urine. If it persists for 3 or more days, so that gives a diagnosis of nephrotic syndrome, that is nephrotic range proteinuria. One can, if in doubt, one can do a protein creatinine ratio in urine. If it is more than 2, as more than 2 is a ratio of protein versus creatinine, both are measured in same values of gram per dl. So if it is more than 2, it gives a diagnosis of nephrotic range proteinuria. 24-hour one can do, but collection is always an issue. And but if one does, the definition is more than 1 gram per meter square per day or 40 mg per meter square per hour of proteinuria. There are these new definitions are there. They have important clinical implication with the current with the current guidelines. So one is we all know what is nephrotic range proteinuria. We have already discussed just now. Remission is once the patient goes into remission, he will be having nil or trace protein for 3 consecutive days, or his urine protein creatinine ratio will be less than 0.2 mg per deciliter. Frequent relapses. So till now the definition had 2 or more relapses in the first 6 months or 4 or more relapses in any 1 year. Now they have included one more thing which is probably relevant, is 3 or more relapses in any 6 months. So if this happens, one will be labeled as frequent relapsing nephrotic syndrome, and it has clinical implication in terms of early introduction of alternate therapy. Steroid dependent, the definition is not changed, that is 2 consecutive relapses on alternate days or within 14 days of discontinuation. Steroid resistance have been changed, and the definition of steroid resistance in accordance with the International Pediatric Nephrology Association, they have been changed to instead of 4 weeks, it is now for 6 weeks. Though the guideline says after 1 month, if you feel the patient is having steroid toxicity, you can give it alternate day instead of daily. But maybe 2 weeks is like the grace period where one can counsel that the patient is steroid resistant and can look for that the patient is actually responding or not. So there are these new terms which are very important, the complicated relapse. So again, even if a single relapse happens with life-threatening complication like hypovolemia with requiring inpatient care, severe infections, and thrombosis, then one should be aggressively treating these patients with alternative therapy or alternative agents, alternative to steroids, so as to prevent these life-threatening relapses. One should also monitor the patients for steroid toxicity. At least these should be done in patients of frequently relapsing and steroid-dependent nephrotic syndrome because they are at very high risk of steroid toxicity. One should look for fasting glucose if it is more than 100, postprandial if more than 140, and HbA1c of 5.7. The patient is having obesity. So this is defined in pediatrics as a body mass index equivalent. So there are charts for boys and girls, a pink chart for a girl and a blue chart for a boy, where if the body BMI equivalent is more than 27 kilogram per meter square of adult, then it's a significant steroid toxicity. The patient has short stature, that is below 2 standard deviation, or height velocity is below 3 standard deviation for the age. There is cataract, glaucoma, there is myopathy, osteonecrosis, or psychosis. So all these, one should actually avoid all these things, and one should manage with alternative agents much before we have all these complications. This new terminology is very important. That is difficult to treat steroid sensitive disease, where the patient is on alternate day, where the patient is already on alternative therapies like levamisole, cyclophosphamide, or MMF, and still having a steroid dependent or frequent relapsing course. So in spite of two agents, if the one has having persistent FRNS or SDNS course, they are difficult to treat steroid sensitive disease, and one should offer them therapies like rituximab or calcineurin inhibitors. So this is a typical nephrotic syndrome which presents to our OPD, a 3-year-old boy having swelling more in the morning, more in the eyes, passing a bit less after the onset of swelling. Gradually swelling has increased and spread to all of the body. There is no atypical features, only edema is there, blood pressure is normal, growth and development is normal, and no dysmorphism. So these are typical case. And how to evaluate such patients? So one should do, in each and every patient, one should do evaluation with urine analysis, kidney function test in form of urea, creatinine, albumin, and total cholesterol, and additional test once if it is required in selected patients. And one should maintain, and one should teach their patients to maintain a nephrotic diary. We'll be seeing the diary in the next few slides. So initially, rule out atypical features. Look for essentially get the anthropometry. Essential investigation is urine routine. Look for RBC cast, RBCs, WBCs, and if there is a doubt of how much the protein is it consistently 3+ or not, then one can get a quantification of protein by urine protein creatinine ratio. Then counts to look for thrombocytosis, anemia, atypical features, blood urea, creatinine, electrolytes, total protein, albumin, serum cholesterol. Still, the guideline mentions that Montauk's test is an essential investigation, probably because our country is still having a lot of and latent tuberculosis in children, and isoniazid prophylaxis might be beneficial in preventing full-blown tuberculosis. And if the child is having full-blown tuberculosis, one has to manage according to the guidelines. And if Montauk test is positive, one has to do an X-ray, one has to do the family survey, and I think more important is taking a history that if somebody is having a COX or symptoms of tuberculosis. A renal USG might be required if one is planning a biopsy, one is thinking about that the patient is having gross hematuria, or there might be thrombosis. There might be of help. If the patient is having gross or persistent microscopic hematuria and you're thinking that this might be atypical nephrotic syndrome, then one should evaluate with the complements ANA and ASLO to rule out proliferative disorders. If somebody has a past history of jaundice, one should do transaminitis and viral markers with hepatitis B and hepatitis C. Urine culture is not routinely required. I will stress on this because there are many times WBCs in the urine, which is common and are mostly thought as that it is probably UTI. But the risk of ascending infection, the risk of UTI is no more in nephrotics than general population. So until the patient is having anomaly in the urinary tract or any other reason, there's no other reason to have more frequency of UTI in a nephrotic syndrome. So urine culture is not routinely recommended, and if it is not done properly, one might overtreat these patients with for a UTI, which is actually not required. So these are the atypical features. Early onset below 1 year. So below 3 months it is congenital. Well, below 1 year it's infantile, and mostly these patients are mostly either difficult to treat or steroid resistant. More than 12 years, there is a quite large chunk of patients more than 12 years who might not be having minimal stage disease. So new guidelines by Indian Society of Pediatric Nephrology says that they can be initiated on steroids. KDIGO still recommend that one should do a biopsy for these children also. So again, we have already discussed gross hematuria, persistent microscopic hematuria, systemic features, if the sustained hypertension is present, and renal failure, which is not attributed to hypovolemia, and if there is suspected secondary cause, these are atypical features and warrants renal biopsy. So coming to the guidelines, the same thing which has been mentioned or discussed previously has been backed by evidence, strong evidence that all these features, atypical features, one should do renal biopsy. Also, if there is early, that is initial or late corticosteroid resistance, one should do a biopsy. Early is, or initial is when on the first episode only the patient shows corticosteroid resistance. And late is when initial responsiveness and later on they showed resistance. Or if the patient is requiring prolonged CNI therapy, or if there is reduction in GFR because of CNI therapy, these are absolute indication that one should do renal biopsy. It's not for what we typically call pre-CNI biopsy. So it is not backed by evidence, but it's still guidelines recommend expert opinion that kidney biopsy should be done before initiating CNI therapy, that is cyclosporine and tacrolimus. Though international guidelines says that one should do all light microscopy, immunofluorescence, and electron microscopy in each and every pediatric biopsies, but the Indian Society of Pediatric Nephrology guidelines a bit conservative, probably because of the cost constraints. So chooses electron microscopy if the patient is actually having suspicion of a proliferative disorder with a gross or persistent microscopic hematuria, having low C3, or a suspected disorder of glomerular basement membrane like Alports. Though ideally each and every biopsy, if done, one should look for one should do EM. Even in FSGS, one has to document is it a primary or a secondary, which can be done by EM, or to look for MCD, which can be if one is doing a biopsy, effacement of food processes, and early membranous. So these things can be picked up by EM, but because of resource constraints, the guidelines put it that it's not routinely required in these patients. So most of our patients in pediatric age group below 12 years has MCD in around 80% of cases, and 90% are steroid responsive. MESPGN, that is mesenteroproliferative glomerulonephritis, and FSGS is around 8% each, and around 50 to 30% steroid responsive respectively. Others are mostly like IgA or secondary systemic like lupus. They are other and rare, and mostly have steroid resistant course. So first episode, the therapy first episode still is still recommendation is 6 weeks of daily therapy with 60 mg per meter square per day, irrespective of when the patient achieves remission. One has to continue therapy for 6 weeks, maximum dose of 60 mg. And ideally, body surface area based dosing is better, especially for younger children, because of discrepancy in the body surface area dosing and the body weight dosing, followed by 6 weeks of alternate day therapy of 40 mg per meter square or 1.5 mg per kg, maximum dose of 40 mg on alternate days. So this is backed by evidence and is a very strong recommendation. That is 1A. So guidelines have seen that guidelines are based on the evidence, and this evidence has come from many trials where they have shown that prolonging the therapy beyond 12 weeks, beyond 3 months, is not going to improve much of the outcome in long term. That the risk of frequent relapses or the risk of further relapses will not decrease with further therapy more than 3 months. And though there is some evidence that very young children might benefit with prolongation of therapy, but still it is debatable. And this is what is currently recommended, that is 12 weeks of therapy. International guidelines, KDO, they says therapy of 8 to 12 weeks is good enough. So 8 weeks to 12 weeks is when where should fall into the treatment guidelines. So this is a typical first episode treatment, specific treatment with steroids and management of edema and other complications, and then counseling. 6+6 is what we call. Medicine is available in the tablet form as well as in the syrup form. One has to make sure that you are giving the correct dose, and then monitoring of weight and proteinuria. And one has to follow up initially every 2 weeks till the remission, and then one can follow up after the completion of alternate therapy. One has to maintain a teach their patients to maintain a nephrotic diary. So so one can put a every morning weight, the proteinuria, how much medicine they are taking, any other drug they are taking, any other symptom they are having. And preferably this should be while the patient is having relapse or while the dose is being changed. It should be done daily. And once the patient is in remission and not on medicine, or not there is no change in medicine, one can do it twice a week. Then if the patient has relapse, so the standard therapy, this is also not changed from the previous. One has to treat with full dose steroids of 60 mg per meter square till the patient reaches remission, that is 3 consecutive days protein nil or trace, and then 4 weeks of alternate day therapy of 40 mg per meter square. There might be in future decrease in this duration of alternate days to 2 weeks, but for now this is 4 weeks. So relapse treatment as previous till remission, full dose, then 4 weeks alternate day. This is repetition of the same thing. Just stressing, it was previously called like 6+6 is the initial treatment, and 2 weeks mostly takes to go into remission, but can be before also. So 2+4 therapy. This is our typical patient of steroid toxicity. She's Cushingoid. She's having high BMI. She's having hyperglycemias. Her blood pressures are high. This most frequently happens when the patient is actually doing doctor shopping, is not following treatment properly, and previous records are not available at how much steroids child has already taken, and land up into this situation. So one should actually monitor our patient, monitor patients for steroid toxicity, especially if you are seeing a patient who has already been treated and you're not sure how much steroid they are on, and they are on, having all these features. One should look for them. So initially there might be reversible changes like weight gain, increased appetite, behavior changes, and they will mostly go away once the steroids are tapered off. And one should look for hypertension in each and every visit, though it's difficult in children, but one has to, at least make sure that they try to measure hypertension, blood pressure in each and every clinic visit. They might be non-cooperative children, but there might be few records which are reliable, and you can decide the therapy based on that. One should take a height every 6 monthly and plot on the growth chart. That is important that you plot it on growth chart. Just putting in the notes will not help the child in long run, because we have to see is the child actually following the proper track or not. If the child is having frequent relapsing or steroid dependent course, one should actually evaluate their eyes to look for any cataract or glaucoma, especially if they are all high dose steroids. And those who are at having significant steroid effects, one should try and avoid steroids and give them steroid sparing agents, alternative agents. So this used to be the previous guideline algorithm, that if somebody is having infrequent relapses, just treat as relapse and follow and monitor. The patient is having frequent relapses or steroid dependent course, then if the threshold of the steroid dependence is low, one can either give a very low dose alternate day prednisolone therapy for 9 to 18 months. And if the threshold is high, one can choose, or there is steroid toxicity, one can choose between the various agents based on the patient's clinical status. Steroid resistance, one has to do a biopsy and base therapy on the biopsy. But the new guidelines, they are more refined. So if somebody is having frequent relapses or steroid dependent nephrotic syndrome, so first one should, one should see the patient can be managed on alternate day prednisolone, and one should try to taper and see the threshold of steroids. If it is more than 1 mg per kg, if the patient is having complicated relapses, significant steroid toxicity, one should straight away go to high doses of MMF, that is around 1200 mg per meter square, and or cyclophosphamide. But if the patient is having not having all these complications, one can manage with usual doses of mycophenolate mofetil, that is around 800 mg per meter square, 600 to 800 mg per meter square, and levamisole. If the patient is having difficult to treat disease, as we have already defined, that patient has failed 2 drug alternative to steroids, then one should manage either with CNIs or rituximab. This is a simple chart which one can follow. A simple chart which one can follow. So levamisole, so it's a good drug, as we saw in frequently relapsing nephrotic syndrome or a low dose dependent. The thing is that it is not costly. It has to be given alternate days, and in some trial it is as effective as mycophenolate mofetil in frequent relapsing nephrotic syndrome. It can rarely cause leukopenia, but generally safe. So one should monitor counts at baseline and then at 3 months. It can very rarely trigger ANCA vasculitis. So at 6 months, one should evaluate for ANCA vasculitis by doing P-ANCA and C-ANCA. Once the therapy is initiated, one should target that at least they should give the therapy for at least 1 to 2 years. The other drug is cyclophosphamide. So again, it can be given for frequent relapsing nephrotic syndrome and steroid-dependent nephrotic syndrome. It's again not costly. The only thing is that it's a drug which the course cannot be repeated again. A course of 3 months, which is around 84 days, 84 days therapy with a dose of cumulative dose of 168 mg per meter, 168 mg per kg of total cumulative dose. One should not try to cross this dose to avoid gonadal toxicity, to avoid other complications. So at this dose, malignancies are very rare, but one should be counseled that in long run it can cause malignancies. Hemorrhagic cystitis can be prevented by giving the drug early morning and keeping a good hydration. It is less effective in age less than 5 years, and it should be avoided in pubertal age groups. MMF is a good drug, but it is costly. It's available in the syrup form also, mainly effective in frequent relapsing and steroid-dependent nephrotic syndrome, and has no major contraindications. But it's mostly less effective in, or not effective to less effective in steroid-resistant nephrotic syndrome. Then calcineurin inhibitors. So there are two drugs here, cyclosporin and tacrolimus. So cyclosporin is a good drug. These drugs, cyclosporin and tacrolimus, so both have similar side effect profile, that both can cause hypertension, both can cause in long run kidney toxicity, and one should actually monitor their drug level. So in Indian guidelines still advice for doing a pre-CNI biopsy before giving calcineurin inhibitors, though we have already discussed about it. So these are the good medications for FRNS, SDNS, which are refractory to medications that is difficult to treat this steroid-sensitive nephrotic syndrome, and they are even effective in immune-mediated steroid-resistant nephrotic syndrome. Cyclosporin is available in syrup form, is very good and effective in young children, where we can't give tacrolimus because tacrolimus comes in capsule form and has to be swallowed, not chewed and crushed by most of the recommendations. But it has a lot of cosmetic side effects, so one has to avoid in adolescents and adults. Tacrolimus is a good drug for adolescents because it doesn't have all those cosmetic side effects, but one has to make sure that the patient is, one has to avoid in patients having seizures, those patients who are having glucose intolerance, already has diabetes or glucose intolerance because of steroids. So one should try and avoid this tacrolimus. Rituximab, this is actually, a very good agent for refractory steroid-dependent nephrotic syndrome, what we call as difficult to treat one, or sometimes in steroid-resistant nephrotic syndrome. One should give it by targeting the B cell depletion. Mostly the doses are given 1 to 4 doses 1 week apart at a dose of 375 mg per meter square. It used to be costly, and the cost is coming down, and with more and more data coming up, it is probably safe, but one should avoid in very young children with the risk of hypogammaglobulinemia and late neutropenias can happen with it. But hypogammaglobulinemia in very young children before they develop lymphoid hypoplasia is probably a important complication which we should be aware of and should try avoid in young children. So infusion reactions, they are mostly manageable. So one has to give it by infusion with all pre-medications to prevent infusion reactions, and they are mostly manageable and does not lead to discontinuation of therapy. Though not backed by a very good evidence, but one can try and give alternate day long-term corticosteroids in a frequent relapsing patient who does not have steroid side effects, steroid toxicity, but the duration now which is recommended is not more than 12 months. So for around 6 to 12 months you can try this. Previously it used to be 9 to 18 months. So probably this will gradually maybe taken care of with a good evidence coming up with better drug available. Good evidence is available for that one should give a short course of daily steroids at a dose of around no, 0.5 to 0.7 mg per kg, or whatever dose currently they are taking. If the patient is having a fever or a respiratory infection has not gone into relapse, so this might prevent a full-blown relapse. Indian guidelines mainly tells that those patients who are currently on steroids should be given this daily steroid for 5 to 7 days, and which is backed by around 3 trials. But there is some studies that even if the patient is off steroid and has been on steroid previously, had difficult course previously, so one can give a short course of daily steroid or alternate day steroid to these patients also at the onset of infection for 5 to 7 days, and it might help in preventing a full-blown relapse. And that actually needs more trials, more evidence, but probably Prednos trial will answer all these doubts better. Coming to edema in nephrotic syndrome, so this is, as this diagram depicts, we don't know where is exactly our etiology or understanding of edema is. There is some points which favor that it is overfill, some points which favor that it is underfill state, but probably not all nephrotic states are created equal, and they might exist at different point of time in same patient. So there is an overfill theory where probably there is increased epithelial sodium channel activity in the renal tubules, leading to salt and water, primarily salt and water retention causing edema. There is ANP resistance and inappropriate ADH, which leads to overfill and hypervolemia. While there is theory where probably there is hypoalbuminemia and capillary leak leading to hypovolemia, and then secondary salt and water retention secondary to RAS activation. So we have evidence, few for underfill, few for overfill. So let's see. Just basic understanding that once in remission, the pressures at the arterial end, delta P, that is the hydrostatic pressure at the arterial end, is around 18 mmHg, and delta mu, that is oncotic pressure at the arterial end of the capillary, is around 14 mmHg. So giving a 4 mmHg difference, which will lead to fluid moving out of the arterial end of the capillary. This is happening in a normal individual. At the venous end, this pressure is approximately 2.8 in negative. That is more of oncotic pressure inside. So this leads to absorption of the fluid at the venous end, and the difference is taken care by the lymphatics. What is happening in the nephrotic state, that this oncotic pressure is decreased in the capillaries, but there is a decrease in oncotic pressure also in the interstitium. It used to be around, if we see, 12, but parallel to the decrease in oncotic pressure in the capillaries, it has also gone down. So the difference here is increased. And in the venous end, there is hardly any fluid which is moving in. So lymphatics has to do a lot of work here. In congenital nephrotic syndrome, there is a very huge difference, so leads to severe edema. But I would like to highlight here that the way, if you see the graph, the oncotic pressure in the capillaries, it is pi p, when it decreases due to the hypoalbuminemia, even the interstitial oncotic pressure, it is pi I interstitium, it also decreases parallel to it. So this happens because of the wash down and the washout effect. So most of the hemostasis is trying to decrease the edema by wash down, that is the oncotic pressure is decreased, and washout where because of the increased pressure, lymphatic will take care and remove the edema. So it is not the change in just oncotic pressure which can explain edema in the nephrotic state. So there might be, or there is probably some component of overfill. So the rate of change of this oncotic pressure might be responsible for the edema formation or hypovolemia at the initial state of nephrotic syndrome. And once the nephrotic state sets in and then salt and water retention takes over, then probably it is the overfill state. So we have already discussed this. So what tells us that probably there are some truth to underfill theory, that we have all witnessed these patients of nephrotic syndrome who comes to us with blood volume depletion, peripheries are cold, blood pressure is low, there's tachycardia, often abdominal pain is there, hemoconcentration is there, risk of spontaneous thrombosis is there. So which tells us that probably underfill theory is true. But there are certain flaws in underfill theory. We can use diuretics into those patients who walk into our clinic and they don't develop hypovolemia. If underfill theory is true, then spironolactone and ACE inhibitors, they should not result in marked increase in sodium excretion, which happens. The first symptom of remission is diuresis. If it is because of underfill state, the first symptom of remission should not be diuresis, because plasma protein level normalizes way later in comparison to decrease in edema. There are patients who are known to have no albumin in their blood, that is being analbuminemic, and there are animal models and they do not suffer from edema. So something else is taking care of the oncotic pressure in those patients. So again, highlighting that it is the rate of change of fall in albumin which probably lead to hypovolemia and underfill state. And once other oncotic molecules take over, and there is secondary salt and water retention, then it's probably hypervolemic and overfill state. And there is probably, we have already also seen that once we give albumin to these patients, some patients actually go into a full-blown volume overload pulmonary edema. So coming to an overfill state, so there are a lot of experimental evidence and some clinical studies which shows that there is primarily sodium and water retention in the kidney, and there is expansion of the blood volume, and some patients actually have hypertension. And there are findings, especially in adult patients, that the renin and aldosterone values are normal. And there are urinary findings which also suggest that there is expanded circulatory volume. Just again highlighting that not all nephrotic states are created equal. This picture also depicts that there is a plasminogen in the urine in the nephrotic urine, and which actually constitutively activates the ENaC channel by splitting the gamma inhibitory domain, which leads to salt and water retention primarily, causing overfill state. But so one can actually do a look for clinical signs of hypovolemia in each and every patient who is having edema. Look for pain abdomen, look for vomiting, lethargy, look for prolonged capillary time, cold extremities. If there is tachycardia, low volume pulses, low blood pressure, and postural hypertension. And clinically, apart from clinics, one can do blood tests, like there will be elevated hematocrit, the ratio to urea to creatinine will be more than 100. FENA will be less than 0.5. Those classically what we read is 1. And if it is below 0.2, it actually it's nearly 100% that this is hypovolemia, because in nephrotics, kidneys are sodium avid state. So even a cutoff of 0.5, there might be a doubt that this is pre-renal state or not. But 0.2 for sure that this patient is having hypovolemia. One can also look for urine potassium index. It's a marker that is aldosterone activated, which will happen in a hypovolemic state. And if it is more than 0.6, it tells us that there is hypovolemia. One can also look for ultrasonography doing inferior vena cava diameter or increased collapsibility, which will tell us that this is a hypovolemic state. So if there is a hypovolemia, then one has to manage with volume resuscitation. If there is the blood pressure is normal, then one can give 20% albumin IV. If there is hypertension, one has to give either saline infusion, or one has to give a 5% albumin can be given. But if there is no evidence of hypovolemia, we have to if the edema is significant, one can first restrict the salt and not exactly restrict the fluid, but do not push fluids. One should not restrict the thirst, because these patients may become hypovolemic because of their nephrotic state. So restrict the salt, extra salt especially. And one can add diuretics, mainly loop diuretics initially at a dose of 1 to 3 mg per kg per day, and may need to add potassium sparing diuretic like spironolactone in a dose of 2 to 4 mg per kg per day. And if there is no diuresis or no weight loss in next 48 hours, one has to double the dose of diuretics to 4 to 6 mg per kg of furosemide, because in hypoalbuminemia, albumin is the one which is carrying the furosemide as a piggyback to the renal tubules for excretion. So in hypoalbuminemia, there is partial diuretic resistance, so one has to increase the dose, no response. And one can then add block at distal to the loop diuretic, sequential blocking to prevent the diuretic breaking by adding either hydrochlorothiazide or metolazone. Metolazone is relatively more effective than hydrochlorothiazide. And if there is still no response, one can give IV furosemide or infusion of furosemide. And at last, one can give albumin, 20% albumin. And here the albumin is being given for edema management and not for hypovolemia. And it's being given as a diuretic to increase the delivery of furosemide to the tubules and to increase the oncotic pressure so as to cause diuresis. This albumin is not being given based on the serum albumin level. So that one has to take care. So one has to avoid giving diuretics if the edema is not significant. So if one is having more than 10% weight gain, probably then one should consider giving diuretics. And one should avoid giving them in patients who are obviously hypovolemic. And if one is giving IV diuretics, IV Lasix, then one should make sure that one gives it with a concentration no more than 1 mg per 1 ml is equal to 10 mg, and not at a rate more than 4 mg per minute. Thiazide diuretics, because they block distally, so one should give them half hour before the loop diuretics for maximal diuresis. One should target a weight loss of no more than 1% per day, because if weight loss happens faster than this, there's a risk of thrombosis. And one should add potassium sparing diuretic because loop diuretics are known to cause hypokalemia. And give albumin, avoid or give cautiously albumin to those patients who are having suspicion of volume overload, and give it very cautiously, the albumin very cautiously to the hypertensive patients. Infections nowadays are relatively, less common in nephrotic states with good immunization. Now, even National Immunization Schedule at some places has started pneumococcal vaccination, and IAP also recommends for long pneumococcal vaccine. So infections are less common in comparison to the past, but still they are documented. So peritonitis most commonly because of strep pneumonia most commonly secondary to strep pneumonia and other organisms. Cellulitis, fungal infections. The first line antibiotic for peritonitis and pneumonia. So mainly third generation cephalosporin like cefotaxime or ceftriaxone are good enough, or one can choose ampicillin with a aminoglycoside. Cellulitis, mostly either coamoxiclav or cloxacillin is helpful. One should be aware of varicella, that it is a severe illness in patients with nephrotic syndrome, and if there is, one should counsel the parents that that the child should avoid any exposure to the patient who is having active chickenpox. But if there is exposure within 4 days, that is the 96 hours, one should give ideally either a varicella zoster immunoglobulin or IVIG. After 4 days, one can give. If one has to treat, one can give acyclovir either in an oral form or a IV form for at least 7 to 10 days. And one should decrease, if the patient is already on steroid, one should decrease the steroid to 0.5 mg per kg per day. That is a stress dose. Regarding immunization, so one should counsel that there is important that the immunization has to be completed, but some immunization might be delayed because of disease and immunosuppression. So killed vaccines, they can be given even when the patient is having relapse or on steroids, but they might be less effective. So if you're thinking that your child will soon be in remission, then one can delay these killed vaccines for that period of time and can give them 1 month after the immunosuppression has been stopped. But if one anticipates that probably they will not be off steroids in near future, so if the patient is on dose less than 0.5 mg per kg alternate day or 20 mg as in adults, so one can give killed vaccines at that dose. Live vaccines are to be avoided until the patient is on immunosuppression or 1 month till post immunosuppression. With the vaccines, which is important from the health program perspective, that is oral polio vaccine. So it's a live vaccine. So parents should be told that they should avoid taking oral polio vaccine at home because it is not under control by a physician, and one has to probably even we can give them in writing in our prescription that they should avoid oral polio vaccine until the patient is on immunosuppression, and they should be preferably given injectable polio vaccine, killed polio vaccine, and the siblings and children who play with the nephrotic child, they should be offered injectable polio vaccine till the patient is on immunosuppression. The other vaccine which are important from nephrotic syndrome perspective is pneumococcal vaccine. So one has to follow the internal IAP guidelines for the dosing of pneumococcal vaccine, but one dose of 23 valent unconjugated PB23 should also be given to each and every child of nephrotic syndrome apart from the conjugated vaccine schedule. One can if the patient is not vaccinated for pneumococcal, one should actually vaccinate these children before starting the steroids. That is, before they start the steroid for the first episode, they can give first dose of pneumococcal to prevent the life-threatening pneumonia and peritonitis. So varicella vaccine again cannot be given once the patient is having active disease or is in or having or on immunosuppression, but once post 4 weeks of immunosuppression, one should give a varicella vaccine, and there should be 2 doses 4 weeks apart. So this has already been discussed. The other vaccine which we should be discussing about is hepatitis B vaccine, because though there is universal coverage, but one should make sure that hepatitis B vaccine is already taken, because of the frequent visits they might get exposed to hepatitis B. Also, influenza vaccine, it should be given yearly to all the patients of nephrotic syndrome, given the increased risk of influenza. And it can be given even when the patient is on steroids, because it is killed influenza vaccine, and decrease the risk of influenza. So there is a venous thrombosis risk in patients of nephrotic syndrome, especially if they are immobilized, having aggressive diuresis, having diarrhea, if there are indwelling catheters or deep venous punctures. If there is renal vein thrombosis, patient will have oliguria, hematuria, or flank pain. In sagittal sinus or cortical venous thrombosis, there will be headache, seizure, vomiting, focal deficits. In deep vein thrombosis, there will be asymmetric leg swelling, which can lead to pulmonary embolism, which can be life-threatening. So there is no role of prophylactic anticoagulation except in patient with congenital nephrotic syndrome. And most important is one should avoid telling children to rest during relapse, and they should encourage their physical activity. And if there is already documented thrombosis, one has to treat with heparin and oral anticoagulants and supportive treatment for a duration approximately around 6 months. So balanced diet with the adequate protein. So neither one has to increase the protein intake, neither one has to decrease the protein intake in a nephrotic syndrome. As we discussed, the guidelines do not particularly, Indian guidelines does not particularly talks about the fluid restriction or how much one should give fluids, but internationally there are articles and evidence where one says if the edema is more than 10% of weight gain is there, one should restrict around 2/3 of the normal. The dictum is don't push fluids liberally, but don't restrict the thirst. Excessive salt restriction is not necessary and should not be done, but one should tell that one should avoid extra salt in the diet till the patient is in remission. And one has to give salt which is make the food food taste acceptable. Otherwise, appetite will decrease very severely. One should decrease oily foods and high calorie foods till the patient is on steroids. And one should encourage normal activity and school attendance. The other supporting measures like antihypertensives, so they might be required once even after management of edema. If the patient is hypertensive, then more than they might be required. The first choice of antihypertensives are ACE inhibitors or angiotensin receptor blockers, and target blood pressure is around below 90th centile for the age, height, and gender. If the child is having long-term steroid intake, one has to give calcium and vitamin D. Antiproteinurics is not indicated in steroid-sensitive nephrotic syndrome routinely. Statins are also not indicated. And stress dose of steroids whenever there is, as we discussed, any acute stress because of infection, one has to give stress dose to either prevent HP axis suppression and to prevent a full-blown relapse. This is about the parent education. One can use charts like this with information about their questions, like what is nephrotic syndrome, is it treatable, what causes a protein leak, what about steroids, and how to recognize that the problem will reoccur or not. Will it damage the kidney, and are the kidney damaged, and can the child lead normal life? So these questions are there in the mind of every parents, and giving a pamphlet like this, handout like this, actually relieves a lot of anxiety and search on internet, which gives a lot of time false information. So each child who is more than less than 1 year or more than 12 year has a family of nephrotic syndrome should be referred to a pediatric nephrologist. Any child who is having syndromic features in nephrotic syndrome, any child who is having features which suggest that it's a proliferative disease, there is severe hypertension, gross or persistent microscopic hematuria, renal dysfunction, and extrarenal features which suggest secondary etiology, should be referred to pediatric nephrologist. If there is complications, resistance to steroid, and frequent relapsing or steroid-dependent nephrotic syndrome, and difficult to treat nephrotic syndrome, they should be referred to a pediatric nephrologist. These are the summary of various guidelines, what has changed over the past 13 years in ISPN guidelines, and what are the new KDIGO guidelines. So we have already discussed. This is the summary of the same. So thank you. I'll be coming up with talks on various nephrology aspects. Thank you so much.